waiting room right now.
Now they're in. I can make you a presenter then. How are you?
Folks, thanks everyone for joining with us
Did you
today.
log back out?
We are just
Okay, you're good. Come on in.
through a little bit of technical issues that should be resolved here in a second, and we will get going right away. Thanks again, everybody.
Good. All right. Cool. I sound like I can hear myself in echo here. Awesome. I will let I can just briefly just say hello while Eric and Matt decide to when we're gonna like move on to the next slide here. Sorry about the little bit of a rocky start due to Mac and Windows incompatibility, which is bane of my existence mostly. You good, Eric? Just give people a couple more minutes. If Eric or Matt, will you just give me like a nod or a heads up that we want me to move on here?
Eric, you want to give your standard intro and then we can get moving?
Come in here and do it.
All right, I'd like to thank everybody for attending today. As you can see, we've been doing a lot of shuffling around and had a little bit of technical difficulty. I'd like to introduce behind me, Dr. Sean Bilodeau. He's our EMS Fellow. He's been with us for the last approximately 3 or 4 months. He has an exceptional background in emergency medicine, came to us from Brown. But he's ultimately today going to talk about rate control shenanigans. We are going to just remind everybody that if you are attending, if you could put your name in the chat feature. I will also send out some announcements about that. You'll have a chance to evaluate us at the end with some QR codes, and we'll put up our new stuff. I will communicate a few things to the chat to everyone so they're available. And if you have any questions, please feel free to reach out to me. If you could throw your license number in there too, that would be wonderful. Especially if you're from out of state, if you could just put your state in there too, and I'll put up some other things. And without further ado, I would like to introduce Dr. Bilodeau, and I'm going to share his screen for him, and we'll get ready to go. There you are, Doctor.
Thank you. All right. So, as Eric said, we're going to talk about some rate control shenanigans here. Yeah, so I am the EMS Fellow, which just basically means that I extended my residency training by another year to spend a time in the pre-hospital environment. We do a lot of kind of 911 response here in Portland and as well some time with Lifeline of Maine. So that's kind of my role currently, and like I said, we are going to talk about some rate control stuff. There's going to be a duplicate slide here. Just want to let, yep, here we go. In addition to myself, Shriji is going to be on with me. Shriji is one of the pharmacists from Brown University Health, which used to be Lifespan, which is where I trained for residency. He's a ED pharmacist, so did pharmacy school, then also did critical care pharmacology, Shriji, residency and fellowship. So he's going to kind of help us out with some of the pharmacology of this topic as well. And like I said, I'm the EMS Fellow through MaineHealth. We have no financial disclosures, which just means that we're not getting paid by anyone to talk about these meds. I have no special devices, and again, we don't have any stock options in the companies that are involved here. And then I wanted to just do a brief clarification. I have friends kind of in all around New England that are doing some EMS stuff. So I just want to acknowledge that we all have different protocols. And what we're going over today is not really to talk about your protocols or what you should be doing based on those particular protocols. We're going to talk a lot about the pathophysiology and pharmacology behind some clinical entities. So that being said, we're going to learn some stuff, but we always have to be in the bounds of our local and state protocols. So I don't want to make sure that's clear that we're not saying do this or don't do this, because that's based on the protocols that you're operating under. And our objectives for the day. So we are going to talk about the anatomy and physiology of the cardiac conduction system. We're also going to talk about why we may need to utilize rate control. And we're also going to talk about the mechanisms and idiosyncrasies of common rate control meds. And then we're going to also try to start the foundations of understanding between rate control and rhythm control. The anatomy here is a little bit difficult over Zoom, but at a very basic level, we're talking about the wiring system in the heart. The kind of yellow circles, if you can see this, so this is your SA node. It's kind of the node that tells the heart when to beat, and the arrows represent the depolarization. So electricity traveling from the SA node through the atrium into this is your AV node, and then down the bundle branch, and the bundle branches, and it splits and kind of comes around the apex and turns itself back up. I put this on here not so that we have a deep understanding of the electrical conduction system, but understanding that there's wiring in the heart, right? And the heart is functionally a pump. And so if we have wiring and we have pumps, we just need to understand how to put those two things together. I think where we get lost a lot is that we focus on the wiring is we think about it being more complex, given a lot of our electrolyte channels, potassium, calcium, sodium, which we'll talk about today. But at its fundamental level, the heart is a pump, right? It's the same exact thing as a sump pump, except that it's not continuous. It just goes. It has a pump. It has a pump action instead of a continuous flow. And if you want the pump to work, you also need to have the wiring to turn the pump on. So we have the pathophysiology of the pump is it pumping enough fluid? And then the pathophysiology of the wiring is the conduction actually happen the way that you want it to? We're going to talk a lot about the conduction, but always understanding that pump is just a pump plus a wire. And so you can kind of break down or have that understanding of what's actually going on. And if we start mucking with the pump or mucking with the wiring, we're going to obviously have problems. So this is kind of to illustrate what happens when you overlay the pump plus the wiring. So the wiring here is the yellow, right? So this is the same picture as that we had earlier. You have your SA node, your AV node, and the yellow is all of our wiring. And so we can kind of follow this little chart starting at 1 in the top left and moving in a clockwise direction. You see how the wiring functions. So an impulse, which is just electricity traveling down the wiring, and then as the impulse travels through the wire, we start activating our pump. And so the purple here is the pump activation, which is basically the squeeze of the heart. And so you kind of can see the yellow meaning the wiring, the impulse travels to the AV node, and as the impulse sits in the AV node for a minute, the atria contract, which is literally the pump of that part of the heart pushing blood forward. And then we kind of continue down the wiring, or the impulse that then goes back to the wiring, down the ventricles. There's a little bit of a pause, and then the ventricles contract and move blood. And then we kind of reset the whole cycle all over again. It's just like when you turn the pump on in your house, like if you turn a light on, if you turn the light switch on, you're telling the electrons, basically the impulse, to travel from the wiring, and it'll eventually get to the light above your head. There is a delay there, right? Because you need to give time for electricity to travel through the wiring and do the thing you want it to do. In the terms of this light, it's turn the light on. In terms of your pump, it's make the pump work. And so if you start looking at your EKGs or even your rhythm strips, what we're really looking at is the wiring system, and we're inferring what happens to the pump. And so this picture, the diagram here, kind of shows the directions of the impulse, but also what happens with different parts of the heart as it pumps. So we know that the heart pumps in two phases, right? It's got a lump and a dub. And so it's the atria, which is the top part of your heart up here, contracts, and then there's a bit of a pause, and then the ventricle contracts. And so if we do this whole cycle one more time, you can start overlaying your rhythm strip, right? And this is just one piece of that, right? So if you look at one beat, so this is one electrical beat, right? As seen on, this is probably lead 2, we can then overlay what happens from the wiring standpoint to what happens from the pump standpoint. And so the colored boxes underneath the QRS complex and the P wave, those are all what your pump is doing. And so as our P wave happens, meaning the wiring is sensing something going through the atria, there's a bit of a pause, right? And that pause is because the electricity is not moving, but the pump is moving. And so the pump is atrial systole, which is squeezing of the atria. And then you see the QRS complex happen because now the impulse is moving down the wiring again. There's not a whole lot happening from the pump standpoint until right about the R wave, and then the ventricle squeezes. And that squeeze is not picked up on the EKG because there's no electricity. So that's your flat line right here, which is your ST. And then there's a bit of a repolarization, which is the whole thing resets, and then we start all over again. And so what I really wanted to illustrate here is that what we're reading on the rhythm strip or the EKG is the electricity. And we're inferring what's happening to the pump, because the pump is what we care about, right? So what we actually care about in the heart is blood kicking out. And so if we understand the connection between the wiring system and the plumbing system, we can start to use that relationship to infer what's going on with the pump by looking at the wiring, because it's really hard to look at the pump in and of itself. And so the other little thing I want to make sure we get absolutely clear is this little orange box here, right? So this is your atrial systole. So this is the time where the atria is contracting. And so this is called the atrial kick, right? And so as the atria contracts, it kicks about 20 to 30% of the blood into the ventricle, right? So the wiring goes through the SA node, through to the AV node, and that little pause in the AV node allows for the atria to kick blood forward into the ventricle. If you remove the atrial kick, you're still going to get about 70 to 80% of the blood will fill up. So it's not a ton, but it's some. So 20 to 30% of our blood volume, meaning the volume that the ventricle pushes out every time it squeezes, comes from the atrial kick. And the atrial kick, go back one here, is reliant on this relationship of your P wave to your QRS. So you need the impulse to travel through the atria, have a pause so the atria can actually contract in order to kick forward, we'll call it 20 to 30% of the blood. Hopefully that makes sense. And so if you imagine what happens if you remove the atrial kick, right? And so the rhythm at the top is atrial fibrillation. The rhythm at the bottom is atrial flutter. And so what's the aberrancy here is that we don't have that pause for the P wave to connect to the QRS. And so therefore we don't get a consistent atrial kick, which means our ventricular preload, or really the blood to fill the ventricle, is reduced by about 20 to 30%. So that's problem one. So atrial fibrillation and atrial flutter, which has the same problem, it's just more organized, reduces the amount of blood that gets kicked out of the heart about 20 to 30% every single beat. So you can imagine that can be a good volume of blood. If we're pumping 5 liters or so per minute at 60 beats a minute, if you lose 30% of that blood flow in every single beat, that's a pretty solid amount of blood. And so that's one of the there's two real problems with atrial fib, which are the whole reason why we're talking about this. That's one of them. You don't have the atrial kick because the synchrony between the P wave and the QRS doesn't exist anymore. So the atria is just quivering, doing whatever it wants to because the electricity, the wiring of the pump are not connected. And so you lose a good chunk of your blood flow being atrial kick. The second problem with AFib or A flutter is that our rates are very fast now. And so if you go back to this, the amount of time it takes for the ventricle to fill up, right? So ventricular diastole. So this kind of light green box starting at the end of your T wave all the way through to the end of your P wave, that's when the ventricle is resting. And so if the ventricle is contracted, you obviously cannot put blood into it. So it fills when it's resting. And so part of that rest period, right, is that atrial kick again. And so really our ejection fraction, which is basically the amount of blood kicked out on every heartbeat, is reliant on how much blood goes in, right? You can't have more blood come out than goes in. And so the amount of blood that goes in is reliant on the amount of time we allow the ventricle to fill, plus the atrial kick. And so AFib, as we said, we remove the kick, right? Because you don't have that synchronization. And then you look at how fast these rates are, you don't allow the filling time. And so we have fast heart rates with low atrial kick. The low atrial kick we already talked about. The fast heart rate tells us there's no ventricular filling time. And so we reduce the amount of blood that we're actually kicking out of the ventricle on every single squeeze by the 20 to 30% from the kick plus a rate dependent amount of blood. Long filling time, you'll kick more out. Short filling time, you'll kick less out. Right. And so you combine the two things and you lose your cardiac output, which we read as blood pressure or perfusion. All right. So that's a lot of anatomy and physiology. Does anyone have any questions about that before we start talking about some of the therapeutic stuff? And I'm pretty informal, so please interrupt me, or if you want to throw it in the chat, Eric can just interrupt me.
Yeah, if folks want to use the Q&A function on Teams, we'll be able to capture your questions that way. Thank you.
All right, cool. So we feel good, yeah? So we need to kick blood out of the heart to perfuse our brains and our kidneys and our liver. We need to kick blood out of the heart by utilizing its pump function. Its pump function is completely reliant on the electrical function, which is messed up in rhythms such as atrial fibrillation and atrial flutter, which is the whole reason why we talked about this, where this concept came from. So now that I've spent 20 minutes talking about the anatomy and physiology, we can talk about what you do. But a little bit of background is that this question is posed frequently. So I have a patient in AFib or A flutter, and their rate is fast, and I want to slow them down, or I want to cardiovert them. And so that's kind of where this whole idea of this rate control shenanigans came from, is what do I do with these people who have fast heart rates and are semi-unstable? So there is one caveat I want to just put up here. What we're talking about here is the treatment of stable or relatively stable atrial fib and atrial flutter. If your patient is hypotensive, not mentating, and unstable, we should be cardioverting them. And so I did not go into synchronized cardioversion. We're going to talk about medications here. And so from this point forward, we were just going to, like, it is a given that all of these patients are stable enough that we're having this conversation, as opposed to going to synchronized cardioversion. So from a medical director standpoint, I get this question a lot. So I have this patient in AFib with RVR, their heart rate's fast, and I want to slow them down. And really, what I'm thinking about in my head when I get that phone call, or if I'm seeing it on scene, is I'm trying to suss out, did the atrial fibrillation or a flutter, we'll call it AFib just so I can stop stuttering on a flutter, is that the thing causing the problem, meaning the poor perfusion, meaning the slightly altered blood pressure, or is the AFib an innocent bystander, as this table would show, or basically a compensatory response? And so that's the entire paradigm of understanding is, do I need to slow this person's heart rate down? Do I think the rhythm, the AFib, is causing the problem, or is the rhythm a response to some other problem? And I'm sure that folks have had frustrating experiences when you call for, in Maine, you need to call for med control for metoprolol. And there's a little bit of hesitation because we're on the other end of the phone trying to figure out via the phone call, is the AFib causing the problem, or is the AFib a bystander? And the reason that it matters is because if your AFib is a bystander and you slow them down, you are likely taking away some of that compensatory response. And so this table is from the Internet Book of Critical Care, which is a wonderful kind of open access emergency medicine critical care. It's not technically built towards the pre-hospital environment, but I use it a fair amount, and the concepts apply really, really nicely. And so this is from Dr. Farkas, who's, again, he's a critical care doc out of UVM, but this is trying to get to the heart of that issue. Is the AFib the problem or a bystander? And what I kind of really want to focus on is looking particularly at that heart rate as a number. There's not a hard and fast rule, but thinking about this as heart rates less than 150 probably have enough of that pause, that ventricular diastole, to get to fill up the ventricle to kick fluid out. So that number is kind of where I start. Like, okay, if the patient has a heart rate of 120, I'm pretty sure that the AFib is not causing this problem. If the heart rate is 180, which you guys have seen in SVT or really bad AFib RVR, like, that's probably too fast. And that gives me another hint that this is probably a electrical problem, like a rhythm problem, not something else. And so it is not a hard and fast rule, but it's kind of my first checkpoint when I hear these on the phone or when I see these folks in the ER. And then I kind of worked down this a little bit. Do they have a history of AFib? If people have AFib chronically, they're used to not having that atrial kick. Like, their body has compensated for that. Whereas if it's a new AFib, that is, your body is not used to not having that 30% of flow. And so you oftentimes get some low blood pressure and some altered mental status. The other stuff, like looking at this clinical context here, right? Were you sick and then had AFib, meaning like, do you have a UTI and you're septic and then you went into AFib? Or were you acting totally fine? You were, out on a run and all of a sudden things changed and you were in AFib or flutter then. Same thing here, right? So do you have some other reason? Do you have sepsis? Do you have pancreatitis? Do you have liver failure? Do you have a UTI? Are those the reasons why you're hypotensive and therefore you're tachycardic to compensate? And then underlying structural abnormality is just something that I think we need to keep in mind for people who, like me, are reliant on that atrial kick, right? So these are people that have really bad pulmonary hypertension, really bad heart failure, some pretty severe diastolic dysfunction, basically. And that means they're reliant on that atrial kick, or they don't tolerate the shortened ventricular diastole, so the shortened filling times. And then there's just a note at the bottom, WPW oftentimes when those people flip into AFib, they become unstable. They're also usually at rates like greater than 200. So it's usually not as much of a conundrum at that point. Cool. So this is kind of when I'm getting the phone call or I'm looking at the patient, I'm kind of going through this in my head very quickly is, do I want to address the heart rate or not, right? And so let's say we want to address the heart rate, and we're going to talk a little bit about pharmacological options here. Shriji, can you hear me?
Hey, yeah, can you guys hear me?
I can hear you just fine. Just let me know. I will move the slides for you. So again, this is Shriji. So he's one of our the ED pharmacists down at Brown. And him and I worked together for a couple of years now, and he was gracious enough to help me out with some of these slides. So Shriji, I'll give it to you, man.
Sounds good, buddy. Hey, well, thanks for giving me the opportunity to come talk to the group about some pharmacology and kinetics of some of the common medications that we use for rate control in not only the ED, but also in the field. So one of the first ones being metoprolol. Here's a picture of the vial. It's a 1 milligram per ml concentration of product that comes in a 5 milligram vial. So essentially one dose for one vial. And we can go to the next slide here and talk about pharmacology. So whenever you have that ending of a drug name being OLOL, that signifies that it's a beta blocker, right? And then when we talk about beta blockers, there's non-selective beta blockers, and then there's selective beta blockers. Now, what does non-selective beta blockers look like, right? Those are your labetalol of the world, esmolols of the world, where they also impact your blood pressure in addition to your heart rate. So metoprolol being the selective one, it only targets your heart receptors. So it targets beta 1 receptors in your cardiac system, and it prevents the binding of epinephrine to those receptors, essentially stopping the triggering of a heartbeat that might happen if it wasn't on board. So next slide, we'll go and talk about some kinetics. So when we think about onset of action and half-life of this agent, the onset of action is fairly quickly. Within 5 to 10 minutes, you start to see the full effect, if not the partial effect at the very least. And the half-life of the medication is about 3 to 4 hours. Typically on the inpatient side, when we have to dose metoprolol IV, we will dose it every 6 hours, just considering the half-life could be as little as 3 hours, just to make sure that there's enough concentration in the body before it's being metabolized. Next slide. So our next common agent is diltiazem. It comes in a vial that is 25 milligrams per 5 mLs. For an average individual, 70 kilos, 75 kilos, usually about 20 milligrams is the dose. So one vial for one dose is the theme of the vial sizes for today. Next slide, please. So how does the pharmacology of diltiazem differ from metoprolol, right? So diltiazem augments calcium channels and decreases the rate and the strength of contraction. Now, it can also have impact on your periphery. So it can impact your alpha receptors in your periphery and cause hypotension by relaxation of the smooth muscle that is in your peripheral vasculature system. So not only does it impact rate, it also impacts the strength of contraction, which is a very key point to point out when we talk about diltiazem as compared to some of the other agents, okay? Next slide, please. The onset of action is similar to metoprolol, and the half-life is also similar. So in terms of kinetics, it's about 5 minutes for onset of action, and the half-life is about 3 hours. Next slide, please. So the key considerations that I noted earlier, right, about diltiazem, why is it important to keep in mind that it also decreases the strength of contraction? Because it is an important consideration to have in mind when you have somebody with history of heart failure. Heart failure patients oftentimes have reduced EF, or they could have preserved EF, which is when it's less of a concern. Still a concern, but less of a concern. So when you have patients with reduced ejection fraction, so their heart isn't pumping out enough volume for proper perfusion, that's when we can negatively impact their heart failure situation by giving them DILT, because it causes a decrease in strength of contraction in somebody that already isn't contracting to enough strength to pump out enough blood to maintain perfusion to your vital organs. In addition to that, I mentioned it can also have impact on your periphery. So the lowering of the blood pressure is a common effect of diltiazem. So always use it in consideration with those that have borderline blood pressure. Next slide, please.
Cool, thank you. I think that's out. I'm gonna pause you real quick.
Yeah.
Shriji, I didn't put this in here, but I'm gonna put you on the spot anyways. What about if you give diltiazem and they drop their blood pressure? Can you just give them calcium to fix that?
No, and that's a common conception that we run into the ER quite a bit. There's been studies that have proved that calcium to increase blood pressure because of a med effect from diltiazem has no benefit whatsoever. So yeah, that answers your question. A hard no.
Hard no. All right, cool. I'm gonna put you back on just a sec there, Shriji. I just wanted to kind of briefly touch base about this idea of rate versus rhythm control as well. We've been talking about rate control, which is, obviously we're using metoprolol versus diltiazem, which is a pretty common area of debate both in the pre-hospital world and in the ER. But there's another way to do this, and that's rhythm control. And so when we think about rhythm control in the pre-hospital world, it's usually with cardioversion. From understanding, you're in AFib, and I need you to not be in AFib because I need your rate slower, and I need that atrial kickback. And so that's really what's happening. You also can chemically rhythm control people. We're going to talk about a medication for that. And while it's not usually the thing that we're doing in the pre-hospital environment, it's certainly something we would do on our critical care transport service when I worked down at LifePact. And you will oftentimes see it. And I want to kind of clarify about what the difference, what we're actually talking about is rhythm control, meaning I want to change their rhythm back to sinus. There is a key piece of information that needs to be from the history here is how long have they been in AFib or a flutter, and if they're on anticoagulation, because there is an identifiable risk that if you convert them from AFib or a flutter back to sinus, that atrial kick is working again, and when that atria quivers, it tends to form a clot, and so if you kick the atria back on, the clot can break off, and then you experience a stroke. And so that's why oftentimes we're asking folks when they come into the hospital, are they on thinners in these folks with AFib? RVR, because I don't want to cardiovert them if they're on thinners and didn't take them, or if they are not on thinners. And then we'll also kind of put this little plug in here is that we, in the critical care realm, we do use rhythm control, especially via the medicine we're going to talk about, because it can be less hemodynamically troublesome than cardioversion. And you don't need to deal with the sedation piece, which we often deal with rhythm control. And there you go, Shriji.
Thank you, sir. So yeah, one of the first agents that we talk about with rhythm control is amiodarone. Amiodarone comes in a vial that's 150 milligram per 3 mLs, and typically your loading dose of amio is going to be 150 milligrams over about 10 minutes or so, followed by an infusion that is at a higher rate. But again, this is more often done in an institutional setting and not generally out in the field. And like Sean mentioned, it could be done in critical transport services as well. So something for us to be mindful of. In addition to that, those statements, right? So there's a brand name product that comes diluted in a bag, so 150 milligrams in 100 mLs. So in terms of the formulation and the active ingredient, there is not that much of a difference. But I will like to point out that there's polysorbate that's in these concentrated vials that's on the slide here that causes hypotension. So polysorbate is an excipient, so it's not part of the active medication, but it is just used to formulate the specific formulation that's in this concentrated vial that is not present in the pre-diluted bag that is also commercially available. Next slide, please. So in terms of pharmacology, I like to refer to amiodarone as a very, very dirty drug. Okay. It has impacts on potassium, sodium, and calcium. And you can see in the diagram that that shift that happens is massive. And that's because it impacts every single step of the way, every single ion that is involved in the rhythm making process and the action potential. So, in summary, very dirty drug. Next drug.
One
slide,
section,
sorry.
Jace.
Yeah.
There's a question about for hypotension, fluid or norepi. Can you, whoever asked the question, I'm sorry, I can't see the chat. Can you just kind of clarify what you're asking there? Like, is it hypotension in the setting of AFib or in the setting of medication? Eric, if not, or well, I guess if we can do it this way. So if you have hypotension in the setting of your AFib, the question was, fluid or norepi, and I think you're really looking at a clinical status there. Like, are you really bad CHF who is also in AFib or a flutter, and you should not give them fluids, or are you someone who is in septic shock and needs fluids? But if you're talking about the medication, and so if you give diltiazem and you're getting hypotensive, again, is it because you're in such bad heart failure and that patient shouldn't have gotten DILT? It would be very hesitant to give them lots of fluids. So norepi or levo can be helpful there. It's also one of those things that it's not necessarily an all or none, and it is not uncommon that we'll use a test bolus. And so if you're seeing some hypotension, even in patients with heart failure, giving them 250 cc's or 300 cc's of fluid and see if they have any response to that can be really helpful. One of the other big things with these folks who are flirting with heart failure is the fluid delivery rate is important. And so if you give them a liter of fluid over 24 hours versus over 24 minutes, that's a big difference about how much you stretch that heart out. And so a small test bolus of fluid is usually what ends up happening first while I'm prepping my levo. I also do a lot of like austere medicine stuff. Something else you can do is actually just lift their legs up. That gives them about 300 cc's of fluid. It's kind of the same thing, and you see if their blood pressure responds to that. Again, if you're like on BiPAP and they can't lay flat, it's not a good look, but that can give you a test of fluid responsiveness. All right, sorry, Sriji. This is the next slide, really.
No worries. Yeah. So the next slide is just highlighting that it alters the flow of several different ions that are involved in the action potential that ultimately results in the heartbeat and the rhythm. So it's very important to just recognize that there's not a single mechanism that amiodarone works via. It works via multiple channels along the way. And that's just highlighted in this slide. Next slide, please. So the kinetics are very variable. All right. There's literature out there in the cardiac world that says you have to give a 10-gram load of amio in total, all right, to have its desirable effect. And then there's some articles out there that do suggest that maybe the onset of action is closer to half an hour for that acute rhythm or acute rate control. So there are variations in onset of action. So I would not expect amiodarone to have a drastic impact on the clinical status of the patient right away. And that's the point of the slide. In addition to that, the half-life is massive. All right. It has tons of active metabolites that hang around for several weeks. Okay. Not days, not hours, but weeks. All right. So when we're starting somebody on this pathway of getting amiodarone, we really have to be cognizant of whether or not this patient is the right choice because it hangs around in the system for a long period of time. Next slide, please. So the considerations here are pretty simple, right? So it impacts a lot of different channels in the action potential. So it prolongs QTC, okay? And we know that, there's a big risk of torsades if we are above 500 on the QTC. So that's an important factor to point out. In addition to that, the oxygen requirement can also increase because amiodarone has been linked to acute pulmonary fibrosis that it happens in specifically cardiac patients. And the study population is in the cardiac unit, not in the pre-arrival status patients. But we can extrapolate some of those things and just identify considerations off of that. So pulmonary fibrosis can happen in an acute manner if we give amiodarone to patients. Okay, so just something to be mindful of. In addition to that, there's many other long-term effects that we need to be concerned about. It's hepatotoxic, it's thyroid toxic, and there's several other systemic toxicities that can result as part of being on amiodarone. So with the half-life being so long, and a lot of these considerations starting to stack up, it's really not a great agent to be messing around with in a wrong patient. Okay. And ultimately that ends the pharmacology section and going over some of the drugs here. And I can answer any questions now, or I'll be hanging around till the end of the presentation and answer them then.
I'm getting little texts if there are questions too, so I'll pop back in here. Okay, so yeah, like I said, if you guys have questions, just put them in the Q&A, and Eric will funnel them over to us so we can try to answer those for you guys. I wanted to briefly kind of go over, kind of inject some evidence-based medicine and kind of go over a little bit of the evidence behind this diltiazem metoprolol debate that is kind of constantly raging. This will not be deep, but this actually just came out this year. I was looking at the efficacy and safety of pre-hospital DILT. This is from Pre-Hospital Emergency Care, which is like the main EMS journal here. This was a retrospective chart review over a couple of years, and it looked at just over 2,000 patients that got diltiazem in the pre-hospital environment. This one's down in Baltimore. You see there, everyone is from University of Maryland or Johns Hopkins. And they found that there was a 68% improvement, some quotes on that, meaning their heart rate went down by at least 10 beats per minute. And then 27% had rate control, meaning it stayed low. And then 3% had an adverse event, which is hypotension and bradycardia. So this study doesn't tell us that it's perfect. It just tells us that it's probably safe. And we already kind of know that. You see this in protocols. But there is a group of patients that can't or should not get diltiazem. This is another study looking at, again, this metoprolol versus diltiazem. This one's in the ER. This is, again, these same patients with AFib with RVR. They did 300 patients. Looking backwards, people got diltiazem versus metoprolol. There was absolutely zero difference in the reduction of heart rate or adverse events. Shriji, I just got a text about lidocaine. Do you have any thoughts on lidocaine? Or maybe procainamide would also probably be in that bucket.
Yeah, procainamide would be in that bucket. I think some of the procainamide studies looked at QRS and whether or not it was elevated or not to qualify a patient for procainamide versus amiodarone. And I think procainamide has a role in therapy, but there's also a 20% risk of hypotension, which is probably a little bit more than amiodarone. So from a risk perspective, procainamide is likely not a good agent to use in the field, but certainly when they're being closely monitored in an inpatient setting or the ED, it certainly has a role. What was the other medication? Was it Lido?
Lido, yeah.
Yeah, Lido is a great agent too, but at some point, we have to consider what agents are being used and if they can be transitioned to PO agents. Lido has an equivalent mechanism to a PO agent that we can use, but ultimately Lido is less preferred over amiodarone because it's an easy transition from amiodarone IV to PO, just to make sure that there aren't any drug-related things that show up with Lido as opposed to its PO cousin.
I would say like I have not used lidocaine for AFib with RVR for rhythm control. I've used lidocaine in codes for like VT and VF. there's the data from my knowledge of it is pretty similar to amiodarone without the QTC problems. But again, for AFib RVR, it's a bit of a reach and is usually like well down that algorithm. All right, let's see. So this, I put this in here because this is the trial that most people talk about. There's like this ED trial where they really love diltiazem, which is usually like anecdotally, if you ask a bunch of ER doctors what they choose, it tends to be diltiazem. So this is like the thing that everyone pointed to though. So this is from the Journal of Emergency Medicine, and it is actually a randomized controlled trial of 58 patients. So say it again, 58, so very few patients. This trial did show that DILT was better at slowing rates at 30 minutes, but there's no change in admission to the hospital, length of stay, or sustained rate control. So I have no horse in this race, but this was an interesting one to me because I learned in training that, DILT was better for the ER, and it's based on this idea, on this study, which was relatively unimpressive, honestly. And then this, I kind of want to bring this one up as well. So this is a meta-analysis, so looking at 1,200 patients of a bunch of different studies. This one found that diltiazem was probably slightly more efficacious, meaning it slowed the heart rate down by about 10 beats per minute. And they found slightly lower side effects with diltiazem. However, this is pooled data, and they had no patient-centered outcomes, meaning like, did you go home? Did you get him into the hospital? Did you have any significant hypotension? It was more based on like a rate control of 10 beats per minute. And sorry, I'm just getting texts as well. So someone else asked if amio takes 30 minutes to act, how useful is it really in a code? That's a really good question. Shriji, do you have thoughts on that before I jump into that?
What was the question again? I'm sorry, I didn't hear that quite well.
So if amio takes 30 minutes to act, how useful is it in a code?
Yeah, that's a good question, and I will go down the pathway that the evidence behind amio or any other antiarrhythmics is not great in a code. Similar to epi in a code, it's not great evidence. I think we just throw the kitchen sink and hope something works, and that's kind of what the algorithm is based off of.
Yeah, I definitely see I've used amio. Obviously, we've used it in codes, but there's also a group of people who are in like VT storm, and so you basically need to like sedate them for long enough for the amio to build up, because there's this idea that you can stabilize the cardiac myocyte with amio, and then whatever your other intervention will work. So like cardioversion. So I've used it for that too. Again, but that's like in the CCU. In codes, I think you're just hoping to stabilize some amount of that, some amount of the myocardium that would trigger like a VT or VF arrest.
Sean, and if I may add one thing here,
Please.
It is perfectly reasonable to give another dose of the amio bolus. So oftentimes it's the amio bolus followed by an infusion at 1 milligram per minute, but it is equally as okay to give multiple rounds of the 150 milligram bolus just to get them up to a level that suppresses some of the VTAC and some of those rhythms.
Yeah, just kind of going through some of the evidence behind this stuff. This is again looking at DILT versus metoprolol in healthy people. Observational study looking at admission versus discharge, and there was no difference whatsoever between diltiazem and metoprolol. And this is our last one here. So this is again acute management of atrial fib in congestive heart failure with reduced ejection fraction. And again, this is an ED-based study. This is again looking at DIL versus metop, and there was no difference in adverse events here. But diltiazem had a significant increase in heart failure symptoms, meaning shortness of breath, but no like measured hypotension. All right. So I have no idea. is the answer to this, right? So we have metoprolol, we have diltiazem. It is constantly being debated. There's no clear evidence that one is better than the other. I think a lot of this stuff comes down to pragmatics. So I have my own algorithm and how I do this, but it is mostly anecdotally based, right? And so we have all these studies looking at comparing the two. Should we add dilt to the protocol? Should we stay with metoprolol? Should we have both? How do we decide who gets what? And really, the evidence is out on a lot of this stuff. I have no clear evidence or data to support one way or the other. I also want to like use this briefly to talk about dogma, and this kind of comes up a lot. It fits the Venn diagram between dogma and like myths in emergency medicine and myths in pre-hospital care is mostly a circle, right? And so if you think about folks who are dogmatic about a thing, right? Like it has to be diltiazem, or no, it has to be metope. If only we had the other one, right? People who are dogmatic in medicine, it's probably because we don't know what the answer is, right? And so if you get people who are really invested in something, it doesn't need to be metoprolol or diltiazem. It can be VL versus DL. It can be ketamine versus etomidate, right? There are a fair number of these things in our clinical practice where people get dogmatic, and that usually should tell you that we don't know, right? If there is a lot of energy behind one particular thing, and another group that's saying that's wrong, it's because we don't have the right answer. So just give that brief kind of thinking about dogma, and just notice that as you go through, as you're training your new pre-hospital medics or clinicians. Like, we shouldn't be dogmatic about stuff, but if you catch yourself being dogmatic, or you hear someone who is, it probably means we don't know what the answer is. And so after this entire deep dive I did into diltiazem versus metoprolol for AFib with RVR, I don't know, right? So I don't have an evidence-based answer. And I wanted, if we have, I have a couple minutes, if you guys will just bear with me. I had this case last night, or actually 2 nights ago, and just briefly kind of illustrates this. So I had a 73-year-old guy come in with CHF, activated to the critical care room. His EF was about 29%, and so if normal is 55 to 65, he's less than half of that. So get pretty bad AFib. Pretty bad CHF. He comes in on AFib with rapid rates between 120s and 140s. He does have blood thinners. He was in his normal state of bad health, and then awoke with palpitations and some chest pain. He took some expired nitro, and so he shows up to us with his chest pain is gone. His heart rate is about 140, and his blood pressure is between 90 and 100 systolic, and he's mentating appropriately, and he's conversant, but his heart rate is really fast. And I kind of stood with the senior resident for a while, and we hemmed and hawed about what we do with this person, right? He's unstable, and that his heart rate is fast, and his blood pressure is low-ish, but he's not unstable enough to cardiovert, and he's sort of too unstable to do sedation for cardioversion anyways. But he has CHF, and we can't use diltiazem because of that. But do we slow him down because his blood pressure is okay, and he's mentating appropriately? And I just used this case. It struck me like how in the middle this person was. Like, I had no clear algorithm to follow, because he's straddling sick and not sick, and medications versus cardioversion, and he's straddling the different types of meds. And what it came down to is you just kind of go with what's in front of you. We ended up kind of sitting on him for a while. We gave him a little bit of fluids. His heart rate didn't change. We said, okay, like his blood pressure then was 85 systolic, and let's move forward with cardioversion. We cardioverted him to normal sinus rhythm, and his blood pressure was still 80, and he had to go to the CCU for cardiogenic shock, right? Not because we cardioverted him, but because we had this complex guy with bad CHF that happened to go into AFib. He was reliant on his atrial kick, and it got to the point where he had lost that atrial kick enough that even with switching him back to normal sinus, he wasn't able to kick back in enough to perfuse, to get a map above 65. And the case is just to say, like, these are really hard, and they're really hard for us with all the resources in the critical care bay, swimming around people, right? And they're even harder when you're in someone's front yard, in their bathroom, on a long transport, and you're faced with this decision of, if I slow them down, that number might get better, but what if their clinical status gets worse? And once you give the med, you gave the med. That's the end of it, right? And so I bring it up not only to commend everyone that's working in this environment for the decision-making process we have to go through daily, but you're dealing with these pretty sick people, and there's real risk to make them sicker. And it just gives me pause about how big of a decision that is, and how it felt for me. And I'm in a resource top heavy place, right? And so just making sure to give yourselves kudos and grace with these are hard patients, and there's no clear answer. And if you call for med control, you're going to get 7 doctors with 7 different takes on it, right? And so that's because we don't know what the correct answer is. All right, with that in mind, for the last 2 minutes, a couple take-home points. So AFib and flutter, the problem is we have too high of a rate, and so we lose ventricular filling, and we lose our atrial kick. And it's that kick, that 20 to 30% that we really need. Beta blockers, metoprolol, and calcium channel blockers, diltiazem, they both work. They're both safe based on our evidence. We don't know which one works better. And so the choice of that med is probably more pragmatic than clinical, except in those with severe CHF, right? We know that CHF and DILT don't mix, but a lot of our protocols and what meds we have are based on availability. So is our hospital filling our meds? Do they have cheaper metoprolol than diltiazem? Is the shelf life of metoprolol different? So kind of that sort of thing. And that goes into a lot of the protocol decisions and the formulary choices. And especially in a clinical scenario where we don't have the right answer, you're kind of left with going to look at other things like pragmatic cost and stuff like that. All right, folks, that is 4:59. So this is just that I could ask you if you wouldn't mind to fill out eval for us. We do take all these and kind of go back to the drawing board each month and kind of figure out what do people want to learn about, how can we make this better. We're so excited that we get to get to work to produce some educational content. We love that we can give free CEHs. And I love that these things keep getting bigger. And I'm hoping I have some folks from Rhode Island from back where I trained on that got to see me again for a little bit over Zoom. So please do that. And then I'm sure Eric will be able to throw this back up again when we're done. But last one here, this is next month. Dr. Williams and Dr. Bohansky are going to talk about pediatric respiratory emergencies. And that subject came right out of the needs assessment that a lot of folks got from Eric Wellman. And it was one of the most requested things. And so they're going to work on an awesome presentation for you all to kind of parse through pediatric respiratory care. That's thank you to all of you for showing up, for listening to me drone on. Thank you again to Shriji for jumping on. So nice to work with him again, but also get another perspective, and awesome to have a critically care trained pharmacist weighing in on our choices and back of an ambulance. Eric, Matt, that's what I got, man. If you have questions, if you got Q's, we got A's.
I want to thank everybody for attending. It looks like we've had a good attendance here. Thank you, Sean, for presentation.
I want to echo that. And Sean, I don't see any additional questions in the Q&A chat or the Q&A. Let me just check the chat again. Thank you all for attending. We really appreciate it. And Sean, thank you so much. Sri, thank you as well. And have a great rest of your day, everybody.